Everybody is.
All right, good morning, everybody. It's 10:30 in the morning, April 22nd, and this is the Tulsa City Council Urban and Economic Development Committee meeting. My name is Anthony Archie from Council District Number 2. First item of business is to call this meeting to order. Second order of business, the ordinance naming Increment District E of the amended and restated Tulsa International Airport Economic Development Plan as Incentive District Number 26, City of Tulsa, and establishing the date and for the creation thereof, ratifying and confirming the actions, recommendations, and findings of Review Committee and the Tulsa Metropolitan Area Planning Commission with regard to Increment District E, ratifying and confirming the action of the City of Tulsa in enacting ordinance number 2347-5. I need to continue on, probably. Sarah's not here. I'll keep on reading.
No, it's fine.
Okay. No, yes?
You stop wherever you want.
Okay,
You just
great.
have to summarize what's there.
Great.
You don't
So
even have to read it.
We're adding to the plan. Okay, so Alex and Jeff are here with us. Thank you for being here.
Good morning. Thank you for having
Morning.
us. So we are officially requesting permission to trigger our fifth and final TIF district, which is within our project plan. It's exciting to be able to trigger it because we already have a company that is starting to develop. The Agile Space Industries Group groundbreaking that we had earlier this year is within this district. And so this is a combined property tax and sales tax generation district. So as they start construction on that, any taxes they paid, we can partner with the state in order to receive some of those funds back and use those funds for future airport development. But it's about 1,500 acres, right, Jeff?
Yep.
Of our about 4,900 acres that we have at Tulsa International.
Wow. Any questions?
How many acres?
1,500.
49. That's good. Great. Well, thank you for the work that you're all doing. Let's expand the tip. Okay.
I have something real quick.
Oh, please.
Thank you for all your hard work out there at the airport. Really do appreciate it, but thank you for bringing Alaska Air.
Yes, you're doing really well, so it's fine.
Yep.
Sure. Jeff, did you want to say
Now I don't
anything?
have to go to.
No, the statutory deadline for activating this TIF is June 16th, so.
Okay. So definitely will act on it before then. All right, thank you all so much. All right, item number 3, let's talk about Kendall Whittier. Resolution directing the filing of the annual assessment roll for the Kendall Whittier Improvement District Number 1 assessment roll with the Tulsa City Clerk, setting June 10th, 2026 as the date of public hearing on the notice of the roll and directing this resolution and notice of public hearing to be published 2 times. All right, Samantha's with us.
Yeah, hi, Sam Extance with the Planning Office. So this is a renewal of the bid. It is in its sunset year, so it's last year. Assessments will end in June of 2027. Changes from the roll from last year to this year. One property's physical address changed, so that doesn't really change much. And then 3 properties zoning changed from commercial to residential, and thereby were exempted from assessment. And so that reduces the annual budget of the assessments by $1,030.11. So the total now that the annual assessment generates is $47,604.31. That's a flat rate for businesses, so what they paid last year, they're paying this year. And just as a reminder, the improvements that funds is landscaping and trash removal, security services, beautification, lighting, parking lot repairs, and then administration.
All right, any questions or concerns? All right, thank you, Sam, for being here. Okay, there is some amended language on item number 4, so I'm gonna read the amended language. Resolution approving the allocation of affordable housing trust funds in the amount not to exceed $269,480 to assist in construction, rehabilitation, and improvements, including 147 affordable housing units pursuant to the agreement to provide development assistance for affordable housing trust funds between the City of Tulsa and TAO in accordance with the economic development incentive policies of the City of Tulsa, Oklahoma. Aaron is with us.
I am with you. I'm going to lean on Councilor Gilbert, since this is her district, for the Oyo Hotel, which takes that hotel and puts affordable housing into that.
Oh, I had no idea.
You had no idea?
I had no idea.
Oh, wow, okay.
Yeah.
So
You're kidding.
No.
Who's working on this?
this came through our affordable housing trust fund through TAO.
This is the one off of I-44?
Yes, that's the,
Nobody's told me anything about this.
you should have been on the committee for this. So I apologize. What I would like to do, if you don't mind, is table this item to make sure that we have the counselor fully aware of what is going on. I apologize that you were not in the loop
Yeah.
on this project, so.
All right. So Sarah, we'll just put it on for,
I would just put it on for committee next week,
All right, for
if
next
that's
week.
enough time, and then leave it on
Is
the
that enough
5
time?
o'clock. It can always be pulled
Yeah,
off the 5
I mean-
o'clock.
okay.
Okay.
Is
Well,
it through economic sorry.
Please, go ahead.
Is it through economic development or housing?
Housing,
Tao?
affordable housing trust fund through
Is
TAO.
that Vicki Jordan?
That's Vicki Jordan, yes.
Okay, so,
But it would have gone through the review committee, which I'm surprised that you weren't.
are you sure it's in District 5?
Yeah, it's I-44.
We've had that too, right? On
But
borders.
But does anybody know about it?
No, I didn't.
No, I just was
We
trying-
share it. We share Yale.
Oh, so probably both should
This is just.
get an update.
Yeah.
I mean,
My full apologies for that.
Well, you don't
We'll
work for
rectify
TAO.
that
Yeah, you don't work.
situation, and we will
Yeah.
get back to you on that.
So these are governed by an economic incentive policy that requires them to go through technical committee and then full review committee. And so, and then it comes
Right.
to the council, so the district councilor's in the full review committee.
That's why I was surprised that you didn't know, because you're supposed to be on the review committee.
All right.
thank you, Aaron. We know you don't work for Partner.
Once
Yeah.
again, my apologies. We'll take care
I
of this.
know.
Thank you.
Oh, that's fine.
Thank you so
Well,
much.
thank you, Aaron. We appreciate you. Okay, well then we will kick this to next week. Let's go to item number 5. Let's talk about IMSA. Discussion with representatives from IMSA, Emergency Medical Services Authority, regarding IMSA's role, IMSA's transport, rate alignment, and treatment in place proposal. All right, IMSA's here.
Good morning, council. Johnny Easley with EMSA. Thank you so much for having us this morning. I do believe that you were provided all the backup documents prior to this meeting. We also have them for you if you'd like them, just to take one
Sure.
and pass around so you can make notes. All right, so I'll start start off with why we're here. First and foremost, I'm bringing to council really two things today. We are asking council in May on full council agenda to approve a rate alignment whereby EMSA will update our current transport rates and bifurcate our rates out in a structure that reflects level of care provided. And then the second resolution would be to implement a treatment in place fee. I do want to be really clear, this is not a request, nor in any way are we asking council to even consider an increase in EMSA care rates. In fact, this would do exactly opposite of that. Our goal is to preserve Fund 121 to ensure your EMS system has long-term sustainability. So the way that we do that is to maximize third-party revenue, so getting insurance providers to pay what is owed on behalf of the patient. That means that the patient is paying as little out of pocket as possible, and that we're able to cover operational costs without seeking fund distribution from EMSA Care, the EMSA Care subscription fund. So I just wanted to set the stage for that really clearly. We've been working on this proposal for a couple of years. We needed to first and foremost ensure that we had done everything internally that we could do from process improvement standpoint in both our billing operations. And then secondly, this proposal was taken to EMSA Board of Trustees for approval in January, late January, whereby it was approved unanimously. And so we're working through the process with council now, and again, our goal would be on the May 13th council agenda. So, Sonia, I'm gonna turn this slide over to you so that you can talk just a little bit. Again, we'll go into the rate alignment proposal, so that's our base rates and our bifurcation, and then we'll switch over into the the treatment in place fee.
All right, so as John had outlined, this is our proposal in a nutshell. We're going to update our base rates to reflect the level of service, which could potentially bring in $1.9 million in additional revenue reimbursement just from the rate alignment alone. The treatment in place rate of $500, we estimate that that will bring in an additional $1.6 million for that service if we start to charge for it. And then the third part of our proposal is to implement a 40% uninsured discount to help defray any impact of rate alignment to our uninsured patients. And then the table shows you the charges, EMSA's current rates, and what we are proposing. The two highlighted items are our highly utilized services. The last item there, the specialty care transports, that is less than 1% of our services. We know that that seems like a significant increase from $1,300 to $2,800. However, those are higher level of services, and so we believe that adjusting our rates to reflect the level of services that we provide is appropriate, and those are typically reimbursed by facilities, hospitals, because those are interfacility transports.
Right, so, oh, sorry.
Well,
I can wait till you guys are done, I'm just getting in the queue.
Up to you.
So he's chairing the meeting, so we'll put our fingers up so he can do it.
Okay.
You don't have, just ignore.
yeah, we'll let you get it all on. Yeah.
Just make sure we put.
I know it's a little disruptive. Welcome.
So we just want to outline what changes and what stays the same. What's going to change is that EMSA is going to update our emergency transport rates for the first time since 2012, as well as implement the 40% uninsured discount, which will be happening for the first time. We're going to expand our charge master to appropriately bill for the care that we provide, and recover costs that are currently reimbursed by private insurers and Medicaid. Our state Medicaid has provided payment and reimbursement for treatment in place since 2011. EMSA has not been able to recover those costs because we did not charge for it. We did not have a charge in place for it. What's going to stay the same, our EMSA Care members will continue to pay zero out-of-pocket costs, and this will not affect them because any out-of-pocket is covered by the EMSA Care benefits. This will not change our mission, our operational structure, or the way we dispatch and respond. Treatment in place will also be covered by EMSA Care benefits, and we are proposing not to charge uninsured patients for treatment in place for the first 2-year period so we can gather utilization data. And EMSA continues to remain the lowest cost EMS provider in the state of Oklahoma year over year.
So the goal of the 2-year moratorium for uninsured is to really understand. We've been studying the data of our patient population for a really long time. But we want to make sure, when you make any change, we want to make sure that there's not a higher utilization than expected, or that we don't see a decrease in 911 utilization. So the next 2 slides are really just basic reminders for councils that the majority of our revenue does come from net patient revenue. So that's revenue, that's reimbursement that we are seeking from commercial payers, Medicaid, and Medicare primarily. The majority of our third-party payer is the most volatile. It's our government, our government-backed Medicaid and Medicare. As you all know, that really depends on current administration and administration budget at the federal level. And so we brace for impact for those every single year, as we are currently bracing for impact from proposed changes in Medicaid. So our goal really is to look at this rate alignment proposal to ensure that we are now really and appropriately putting the value on the care provided, meaning that, back in the day, CMS had a few HCPCS codes or a few codes by which you charged for services. Obviously, over the years, that has expanded. We have not expanded that. So if it's an emergency ALS or BLS, we charge one rate no matter what intervention is provided. And so if you require whole blood, right now, we can charge at a higher rate for that. Whole blood costs us about $500 per unit, and it puts it in a higher level of care. If you don't require an intervention like that, obviously the care is fee-based, so it's at a lower level. So I just want to be really clear, we are not changing the way we provide care. We're really just bifurcating out our levels of care so that it reflects what's being provided on scene. If you want to run to the next slide, Adam?
So I just want to, Adam, will you go to the previous slide? So as Jonna mentioned, we're really trying to maximize our reimbursement from the commercial payers. Oklahoma passed a balanced billing law which tied reimbursement either to the lesser of locally approved rates or 325% of Medicare. Now, most insurance providers prefer the 325% of Medicare because that is typically lower than what providers' approved rates are, except for EMSA. Go to the next slide, please. So EMSA, these are EMSA's current rates, and the last column shows you the 325% of Medicare's rates. So that is the negative that we could make up if we adjust our rates as compared to what it currently is.
So basically what we're saying in this slide is that insurance companies have actually adjusted their charge masters long before we adjusted ours. And they're actually reimbursing at a higher rate than we're charging. So they recognize the need to increase reimbursement, and we're just a little behind the game.
So are we leaving this money on the table?
We are leaving this money on the table.
Okay.
Really, that was a rhetorical question, Counselor?
I just wanted everybody
Are
to
you not
know,
the-
in other words.
Are you still the chair of the trust?
No,
Are you still on the trust?
yes,
Okay.
the authority,
Okay.
yeah.
Thank you. So, since, again, we haven't updated our rates since 2012, and what we have seen across the healthcare industry is a 43% inflation rate. So since 2020, EMSA directly has seen a 55% increase in our cost to procure ambulances. We've increased our wage and compensation to all frontline providers by approximately 32%. Our capital equipment and supply costs have gone up 25 to 30%. And so, again, as Counselor Lakin mentioned, We do have opportunity to recoup costs by third-party payers. As always, our goal is quality patient care. This, again, does not change our model. Our goal will be to recoup as much as we can from insurance providers, whereby our patients will pay as little out-of-pocket as possible.
Right, so we did a comparative analysis. We looked at cost of the same services. We compared organizations across the country, and we also looked at organizations around us, so our neighbors. And this is where EMSA's proposal lies compared to some of the other communities around us. We have some patient perspectives here because as one of EMSA's value is being patient-centered. And so we wanted to look through the eyes of the patient to see what this would look like for a patient. So we have a patient example, and we kind of outline what that would look like if the patient's an EMSA Care member, if they're not an EMSA Care member, or they're uninsured. The bottom line is that if they are an EMSA Care member, they will see no changes with our rate alignment. If they are insured but not an EMSA Care member, then they will pay whatever their insurance determines their copay is, which typically is determined again by their insurance company in a contract. And then if they're uninsured, they will actually see a reduction compared to our current rates with the implementation of that 40% discount. So just going over, looking deeper into treatment in place, again, just reiterating what Jonna has said. Treatment in place is not community paramedicine. It's not a new line of service that EMSA is proposing. These are emergency requests for services that we already respond to, but the patients decide that they don't want to be transported. We just don't have a way to capture that specific reimbursement. Typically occurs when patients call 911, we complete an assessment and we provide treatment. So an intervention is necessary in order for this, and then patients can refuse to be transported to the hospital. We estimate that for Tulsa, we spend about $7 million annually providing the treatment in place services, and we have the ability again to get reimbursed $1.6 million. This is just some data showing how we got to that number of the anticipated revenue compared to our annual responses. Again, a patient perspective. For treatment in place, if they are an EMSA Care member, EMSA Care benefits will cover any out-of-pocket they might have. If they are insured and not an EMSA Care member, then if we have a contract with their insurer, then they will prohibit us from waiving any out-of-pocket costs. And if they are uninsured, we are proposing waiving all out-of-pocket costs for a 2-year period. So just to summarize everything we've talked about, I think it's everyone has been listening to the news. We hear a lot about Medicare and Medicaid reimbursement and the healthcare financial struggles that everyone is experiencing, both hospitals and including EMS as well, because the reimbursement is always at risk and they reimburse below the cost of providing the services. We actually have already seen some impact in that, where our uninsured population is increasing, and which will lead to uncompensated care. So again, our charges are lower, and because our base rates have not been changed since 2012, we are now basically underbilling for our services, and the reimbursement that we stand to get from that. So, Donna?
Yeah, I think just to wrap it up, again, I wanna be really clear, no change to EMSA Care. Our goal is to be, for long-term sustainability of your EMS system, to include Fund 121. We have not, our draw on Fund 121, my goal is to decrease it every year. It has been flat for the past 3 years, even though operational costs have gone up. This is just additional revenue that is available to us that would then require us to rely on those sources even less. happy to answer questions.
For sure, we have a little bit of a queue. So, saw Counselor Bellis's hand go up. Counselor Gilbert, did you put your hand up? Or were
I
you
did not.
Okay, you did, okay. So after Bellis, we'll have Dutton and then Counselor Dr. Wright.
Yeah, I just had a few clarifying questions about some of like the rates, which it totally makes sense to go, hey, we weren't able to capture this from our billing because we weren't billing for it. I was curious, do you all though, and I'm so sorry if you said this and I missed it, do you all have a difference between what's billed to insurers versus out-of-pocket rates? Like for instance, when I wasn't sure if this, because I know sometimes like, in a hospital setting, right, for example, they would be like, hey, this is what we would charge someone if they're paying like cash versus what would be billed to an insurer, so there's not a difference there?
No,
Okay.
and that is because our rates are approved by our board but set by council, so we have.
Okay. Is that something that's feasible though if it was approved? This is just a curiosity because I know other medical settings that do that difference between,
So-
hey, we could get this from insurers if we build up to this level, like that's what they're, like whatever, whether it's Medicaid reimbursement or otherwise, versus, hey, if someone had to pay out of pocket, this is the flat rate we charge them.
Yeah, so that's, what we're doing is what is typical in the healthcare industry. I've worked in a healthcare hospital system before, and what they do, the patients don't see it, but it's exactly what we're doing, where there's a set
It's that
charge,
discount.
and then there's a discount that is applied after the fact, and they just calculate the discount to the
And
bill
that
the
becomes that
patient
kind of
sees.
out-of-pocket rate, I see.
Correct.
Okay.
Yes.
That's helpful, that's why I was kind of curious if that was operating that way. Okay, that's helpful. And then for your all's calculations, I appreciated also that kind of like that 2-year moratorium, which also kind of fits with some of the federal and state level Medicaid instability. Is that part of your all's calculations budget-wise, where should we see more significant cuts to Medicaid and thereby a lot more uninsured folks within the region? Does that 40% still math for, like if you're doing that kind of discount rate and you have more people that are paying out of pocket, does that math still work for you all to?
Yeah, so the answer is yes, and 2 reasons. Number one, we wanted to make sure that we are preserving the value of EMSA Care. Excuse me. And so our 40%, 40% reduction is comparable to what we offer in current EMSA Care. We go into every year projecting what, based on what we're hearing, what the chatter is, and what we're seeing across the industry, projecting a variety of cuts to our government payers.
Right.
So we look at that every year. I think we're very conservative in our budgeting practices for that reason.
Makes sense.
And our trustees know that as we bring our budget forward, that our major payer, right, is the most volatile. So we would be irresponsible not to consider what that would do in an annual fiscal year.
Yeah, that makes sense. And then, just as a last question, related to the treatment in place concept, I'm curious what the delineation is there. One, I'm curious about why it was 0 before, which I'm glad you guys are seeking to get that revenue. But then 2, just as an example, I think there's been a time where I've called 911 because I saw someone who was unhoused outside and I couldn't tell if they were alive or not, right? And CRT or whoever wasn't showing up. I was a little reticent to disturb them if they were just asleep, but I thought they might need medical care if they've been outside that long in the cold. And so EMSA shows up, folks, team hops out of the ambulance, real quick checks, the person wakes up and goes away. And I can tell that probably happens a lot actually. They were used to showing up and going, oh, actually this person's fine. They just needed to wake up and go inside somewhere warm probably. Is that that's not really but you did have to go out there. So I just wasn't sure at what point we're rendering treatment.
Sure.
So it's not that.
No,
Okay.
so treatment in place really has parameters established by CMS. So treatment requires treatment. So if we come out and we do an assessment on a patient and the patient says, I'm good, then, they sign a refusal, just like they do now.
Okay.
If we provide intervention, so think about, maybe you're diabetic or the patient is diabetic. We do IV intervention with dextrose, and the patient says, you know what, I am a brittle diabetic, my wife's in the other room, I'm gonna eat, and I'll check in with my primary care. We now We leave aftercare instructions. We encourage the patient to call 911 again should their condition worsen, and we leave. In this case, that patient, because we did do intervention, we provided medical care that we are not able to recover costs from. So I hope that answers your first
Yeah, that
question.
did. So it's,
This-
just to clarify this, you mentioned, so you could do an assessment and that wouldn't be treatment, which I get that
Correct.
that's different than treatment. I just wasn't sure at what point you kind of trigger into being able to bill and reimburse versus,
Yeah.
okay.
So intervention is what we call it, and so
Okay.
if we're doing intervention, rendering actual medical care, that's when we would trigger in the
Okay.
TIP. I think you asked another question?
No, I think that actually covered, I was just making sure I understood at what point it would then be something you could bill for, which you, yeah.
absolutely.
Cause like, for instance, that is like, or, you know, also just for the public's knowledge too, so someone could show up and help, like, take someone's heart rate and do some basic checks, and that's not,
Correct.
okay, but it's at the point that you're administering some type of care?
Yes.
Okay.
And I actually think your question was, why has it gone
Oh, yeah,
to
why,
zero? So-
why was it zero, yeah?
Yeah, so a couple of things. Treatment in place is, in terms of healthcare billing, relatively new. It's only been around in the EMS world for, maybe 10 to 15 years. There are some insurance providers that, like state Medicaid, that recognizes it is much cheaper for them and more feasible for them to pay a treatment in place fee than for their enrollee to go to the hospital and have emergency care or have an emergency bill. So it's relatively new in the EMS world, number one. Number two, we simply haven't had a fee structure in place in EMSA to be able to do it. Why have we not brought this before? My honest answer is, number one, I've only been the CEO for 4.5 years, so I can only tell you about the last 4.5 years. And our focus was really making sure that we were doing everything we could from a reimbursement perspective, a process improvement perspective, to make sure that we had everything under control and that we didn't leave, that there wasn't anything on our side that we could do. And then we started to identify now, here are the other ways and the other opportunities for us to seek revenue.
Actually, as one last clarifying question from that, is that kind of, so, out of curiosity, is there, when you're administering treatment in place, is that kind of like a bundled fee for whatever happens there, or can you also then bill for what actually gets administered more specifically is on top of that, or how does that?
So we only have one set rate, so, right now. So
Okay.
if it's so in our current fee, if it's ALS emergency, it's $1,300. We get reimbursed that if the patient gets transported. It doesn't matter what we do on scene.
Okay.
And this would be the same.
Okay, thanks, that's helpful.
So we're not itemizing, so
Mhm.
for every, blood pressure cuff, for every needle, for every thing, it's not itemized.
Okay, thanks so much.
Yeah, sure.
All right, Counselor Dutton and Counselor Dr. Wright.
So I'm looking at the percentage of coverage by Medicare, Medicare Advantage, Medicaid, and Managed Medicaid, and that's a total of like 71% in the graph here. And there are multiple bills at the Capitol right now that are looking to cut funding for citizens and leaving the Medicare and Medicaid into the hands of legislators in Oklahoma City. And so I was looking at the number of uninsured in Tulsa, and it looks like we have 27.4% uninsured, 29.4% uninsured population that is dependent on the Medicare and Medicaid, possibly, and then 28.3% Hispanic population. So those are kind of high percents. What's going to happen after the 2-year term of treatment in place pilot that's
Yeah.
going to be implemented?
So, the goal for the 2-year moratorium is really for us to ensure, when you make a change in fee structure or you make a change in operations, there needs to be a window of opportunity to make sure you don't have any unintended consequences, right? So, again, we have years and years of patient population and dispatch transport data. What we're wanting to make sure is that by implementation of a fee, that we're not seeing either an underutilization in that particular dispatch code or in that particular patient population. Like, we don't see a drastic drop-off, and/or we don't see an increase. So we don't see people calling 911 more often because they're an EMSA-Care member, and it would be easier than going to an urgent care. We want to make sure that people are getting the right care that they need, but in no way are we discouraging them from calling 911. So at the end of the 2-year moratorium, number one, we look at our transport and run data monthly. So we will be able to catch very early on if something is going on in any one of those buckets of our patient population. Our 2-year moratorium, as long as it goes as expected, then the treatment in place fee will begin to bill those to patients. And then, Sonia, do you want to talk about what we expect from?
Yes, so we will bill those patients at that time, and just like we have proposed, if they are uninsured, they will also receive a 40% reduction in that fee as well. Today, if you receive healthcare services from any other healthcare entity, you do not expect for those charges to not show up. And so it's just really aligning our services with the rest of the healthcare industry, where if you receive services, then you expect to be charged for it. We're hoping that a lot more people will sign up for EMSA-Care and see the value add that EMSA-Care is, because if they are EMSA-Care members, even if they're uninsured, then they will not have to pay out of pocket for treatment in place in 2 years' time when we roll it out.
And we won't retroactively bill any uninsured patients once the 2-year period ends. There's not gonna be any bills that come out from something
Right.
that happened in January of 27.
And what does it look like with your bilingual providers for EMSA? Do we have?
So we do have some bilingual providers, but unfortunately, the way that, our system, our goal is to get the most appropriate care to you quickly. So if we happen to have a bilingual provider on unit 142, but the closest ambulance is unit, 147, we're gonna send unit 147. We do have a variety of translation services available to our patients and our providers.
In the form of?
The language
The
line.
language line.
Language line, which is what the City of Tulsa's 911 center uses. And then we also have our community engagement manager who sits on the Greater Tulsa Area Hispanic Latinx Affairs Commission. We will be creating Spanish language documents as we sort of do the EMSA-Care open enrollment that would coincide with the implementation of this. So we do have a two-pronged approach to reach that. We've done the bilingual EMSA-Care ads for 8 years, and we have several Spanish language resources on our website.
Okay. And then one final question. The 32% increase in wage and compensation, when was the last time there was an increase in wage and compensation?
Last July.
Last July?
Mhm.
And so we're requesting a 32% on top of that?
No, that 32% is our increase in wage and compensation over the last 4 years. So basically, it's just another avenue. Our wage and compensation budget is one of our highest line items. And so as we are, we're just showing you the increases in our cost to operate your EMS service.
Do you see the little asterisk
Yeah.
on our handout? It's not, well, I don't, that's why it's not even up that we're talking about, number 8. It's 2020 to 2025, 32% over those 5 years.
Yeah, that's right.
But, yeah.
Still, I think the public would like to know.
Sure, of course.
Councilor Dr. Wright.
Thank you. As we know, post-pandemic, these frontline healthcare worker jobs are hard to fulfill and sustain because it's the whole whole world got real nasty about that. I mean, I don't know about you, but when I pick up my prescription at Walgreens, I have like a warning about, you better be nice to our pharmacist, and, you know.
Oh, yeah, they do.
Yeah, healthcare providers are literally being violently attacked, and we've seen incidents of ambulance drivers getting punched through the window and things, so. I have questions, which I'm sure will be no surprise that they're coming from me on this, but I'm just, for our friends in the room, their friends at home, as we're having this conversation, with EMSA's change in the Eastern Division with beneficiary and non-beneficiary cities, has that, like, is the volume remained the same, and is any of this cost adjustment, revenue enhancement adjustment related to service area changes for our division?
So I'm happy to answer that. The truth is, we've actually seen an increase in transport volume in Tulsa. While we have lost non-beneficiaries, so again, the city of Tulsa and the city of Oklahoma City are the only members of the EMSA Trust. We have lost non-beneficiary members, and we have seen, so the way that it is budgeted is they're only charged for their patient population in terms of what their piece of the EMSA budget is. So none of this is related to that. Again, we have quickly, and honestly, unfortunately, absorbed any volume in Tulsa, the city of Tulsa proper, for the non-beneficiaries. And I say unfortunately because what that means is our residents are using 911 a little more often. And then we've also seen population growth.
Because of the non-beneficiary cities leaving the trust, our residents are using?
No,
Oh,
I just
okay.
mean, so
I was
we
trying to
have,
follow track there.
sorry, we have quickly absorbed any loss of volume from.
We're making it up the
from-
difference.
yeah.
And do we anticipate, so let me just reflect back to you what I heard.
Sure.
When non-beneficiary cities left,
Mhm.
you just adjusted operations according, like the outline of where you were
We just
serving
moved-
shrunk, but the number of people that are using the services didn't necessarily. But there was a loss in revenue when those non-beneficiary cities stepped away, or no?
I mean,
Negligent,
sure,
or-
briefly, and if we, I guess you could say, you know, I'll take the city of Sand Springs.
Sure.
So let's say that their patient population was 5,000, right? I mean, obviously, depending upon their payer mix, we would be generating revenue in some capacity
Yeah.
for those 5,000 residents. Our operation model didn't change. So what we did is then take those resources and redirect them back to the city of Tulsa proper. We didn't have stationary posts out there. Those were always outlying.
Okay.
And so sure, there, you could say that those 5,000 calls, we could have seen a slight decrease in
Sure.
revenue. Unfortunately, we have quickly seen that.
Picked up those 5,000
Yes.
in the city limits. Okay. As we know, our system's designed for TFD to respond to certain priority calls.
Mhm.
So, if TFD as designed gets to the patient first, EMSA's on route and getting there, and the patient refuses this transport, can you talk about how this treatment in place would be handled? Who gets
Sure.
billed, or does anyone get billed?
Yeah, so primarily, if the system is working as operated, then Tulsa Fire, our Tulsa First Response Partners are going to respond on our highest acuity patients. The majority of those should be transports. So.
Okay. Just because of the prioritization?
Yes, the
On the
prioritization.
call.
But, let's say, for some reason, not, it depends. If Tulsa Fire responds, gets there first, does an intervention, we do not bill for interventions done for other people. And so only if care is handed over and we do an assessment and an intervention, would a resident get a bill for treatment.
Okay, and TFD is not billing for treatment in place that I'm aware of, so just throwing that out there. Sometimes people,
Yeah, Tulsa Fire doesn't, they don't
they
bill.
don't bill for anything.
For anything,
It's
they're
a
funded out of
service.
general fund.
That's right,
And then a small portion out of EMSA Care.
right. We do that reimbursement. We made an adjustment a couple years ago on supplies.
And then we do one-for-one pharmaceutical and supply on scene.
Yeah. So the final thing, because we did make an adjustment on some insurance billing related to hazmat services that fire does. perform, and then we got a little bit of concerns elevated back at us about what that does to premiums, and so that's my final question is like, if EMS agencies across our state start billing for this treatment in place, could those claims eventually cause the insurance companies to adjust those premiums for people that are privately insured?
We do not anticipate that to happen. Other states that have implemented treatment in place, we have not seen, or they have not seen an increase in premiums, and premiums are unrelated to the cost of ambulance services. They're typically aggregated to the group, depending on if it's employer-sponsored or state-sponsored. It's really based on the total healthcare spend, of which ambulance is a very minute part of that. We've seen premiums increase for so many years. I've never had an ambulance transport, knock on wood.
Right.
But my premiums have
This is
increased
your day.
year over year over year.
Sure.
So we do not anticipate for treatment in place to then cause an increase in premiums across insurance
Yeah.
providers.
Incorrect.
I'm just
Wrong.
wondering a little bit, I mean, this is just me thinking out loud to policymakers. Thank you for mentioning that there's some moving bills down at the state that could impact one way or another our constituents around healthcare. We know that a larger segment of Oklahomans, including Tolsons, are using emergency calls as like, rather than prevention or even like minute clinics, whatever. So I would like on the 2-year tracking, if we can look at some data that says like more people are doing the treatment in place, refusing the ride, but getting, the thing that maybe they would have gone to urgent care for. Just curious.
Yeah, and correct me if I'm wrong, but the TFD hazmat would be automobile or vehicle insurance? Is
I
that-
was just referencing to
Yeah.
my colleagues that we made another policy decision that it was like, we're leaving money on the table.
Yeah.
Companies would reimburse for this if we could find a way to bill for it, so we hired a third party. We were like, okay, because we also had a directive to all these departments to find revenue and contain costs, which is what we do. And so that's what they did, and then community members came to us and said, this is going to impact premium. So I wanted to learn from those decisions and make sure we were doing an if-then model here for us on the decision-making tree.
I think the 2-year thing that you.
Yeah, I just,
That'll be helpful.
since
they'll
you're
provide some
designing
really
the
good data.
tracking, if you can just also, see like, can we look and see, and I don't know what kind of surveying happens in the field, like, are you refusing today because of concerns about pay or what? I just don't know.
Yeah, so our goal in the field is patient care, quality patient care.
Sure.
So we do not ask our providers to collect insurance information. When we dispatch, we do not know if you have insurance, if you're uninsured, if you're underinsured. We handle all of that on the back end because we want our providers to focus solely on the patient in front of them.
But on the back end, do you get that information, insured, uninsured? I mean, when I was in my 20s and would get like an offender bender or whatever, and they'd be like, do you want to transfer? It was like, I was already doing the if then, what is my bill gonna be, and do I really like, do I really need an ambulance ride? You're sitting in the middle of the freeway in shock trying to make these decisions. So I know myself, when I was on a limited income, I definitely was running those scenarios and doing things like, I'll just take myself or whatever. So I know it's on people's minds. I think the big takeaway here for us, aside from, having to vote on these things, and Oklahoma City already voted, right?
No, so
Oh.
Oklahoma City will vote, this goes on the Oklahoma City council agenda on May the 19th.
6
Okay.
days after.
So we have some time here to engage with constituents. For those of us that have town halls regularly, or even just our social media or whatever, we have someone in code enforcement that specifically looks at the multifamily and does an assessment as to whether or not they're, as a property ownership group, enrolled in EMSA care. If they're not, individuals can enroll on their own, but I still think that needs more amplification from us. So at town halls and things, if we can have those flyers and those descriptions of how people can, if they're all bills paid or whatever their situation is, they can still do this $6 a month, or what, it's a one-time fee, Adam, what is
Yeah,
it?
so
It's $80 a year or something.
We have purposely set the implementation date as October 1st, which
Okay.
is after the City of Tulsa's open enrollment month in August and the City of Oklahoma City's enrollment month in September. We are going to do about a 2.5 times larger engagement campaign, and a lot of that, will be focused on explaining how people check if they're enrolled or not, and then if they're not enrolled, how they go about doing that. You're exactly
Right.
correct with code enforcement. multifamily housing, it does get, you know, it's a little more muddled than the single family. But landlords are required to give their tenant a waiver that acknowledges that the tenant understands that or that property is opted out of MSACARE, and here's how they can join independently.
And does MSACARE go with the address of the residence or the person in the residence?
So for the city, it's with the utility accounts, which
Okay.
are tied to single-family homes, but the direct subscriber is for a year, and it's
For the person.
for the person.
Okay.
And it's $65, which is the $545 monthly fee times 12, and you can actually join that at any time during the year. It's just not prorated.
Okay.
But we will be doing a robust public engagement and communication campaign, including some town halls and direct mailers to landlords, explaining what's happening and
Yes.
how they can.
And I think as we've learned that 50% of Tolson's are renting, and we know our communities, I think it's important that we just make it part of what we share with communities, because it can be confusing if you didn't grow up here, you're a transplant, it's all of a sudden like, what is this? And, I think more often than not, probably you can share anecdotes. People discover like, I should have been paying the $6 a month or $5.85 once they get that first bill for a ride. And then it's like, a little buyer's remorse, so,
Yeah, and I've been to several of the town halls and events that counselors put together. We are happy to explain MSACARE, how to sign up. And like I said, we're gonna be doing a much more robust campaign, because there are some changes that we wanna make sure that our residents are aware of.
For sure. Anything
Yep.
else?
No,
Okay.
thanks.
Counselor Latham?
I just, on MSACARE, how many of our residents,
So-
72%?
It's like 70.7% of single-family households are enrolled. There are two opportunities, that month
Yeah.
of August, and then at the start of service. So, we work with Customer Care Center to make sure that the scripting and language accurately tells the person setting up service what's included. But also, if, 45 days later, you're like, wow, I should have signed up for that, you still can directly with us.
Yeah.
But we have we have no intentions of changing anything with the MSACARE marketing. We still wanna talk about the benefits, but we definitely wanna make it a little bit more visible about what's changing. Because we think that the treatment in place aspect is gonna be a huge member benefit.
It's so beneficial, and you're not really affected by this change if you have MSACARE, so that's.
At all, you wouldn't notice
Yeah.
anything.
Yeah, and we're not trying to sell more MSACARE memberships, it's not like a membership anyway, but there are those benefits, and you don't have to worry about it if you do have an accident on a freeway and you're 23 or whatever example you use, Counselor Dr. Wright. It's just taken care of. You get the care that you need, and everybody else takes care of everything else from that point forward. Okay, that's
Yeah,
all.
well, wonderful. Anything else from anyone? All right, well, thank you all for being at the table.
Thank you for your time, Council.
Thank you.
Final agenda item, well, number 6. Travel authorization per council rules and order of business is the estimated amount of $1,550 for Councilor Hall Harper to travel to Omaha, Nebraska to attend the 19th Annual Rebuilding the Village Conference and Revive Black Business Expo to be held May 5th through the 8th, 2026. This is for her flight, hotel, and per diem. And Sarah, will you share about this, or?
Yes, Councilor Hall Harper can tell you more about the event, but so your council rules require that if your annual travel exceeds $500, then it needs to be approved by council, and we put it on the committee agenda. And so there are sufficient funds in the travel account for the counselor to attend this event. And then we did just put a note on there that there was a flight credit, so it actually won't be quite at that $1,500 level for this event.
Is it with Spirit?
What?
Sure.
What?
Yeah,
No,
I said
no,
it
no,
with
no, it
Spirit.
wasn't.
Temporary customer.
Yeah.
they're
Doesn't matter
bailing
who
out
it's, doesn't
Spirit.
matter who it's with, we're all
Sure.
canceling.
Yeah, yeah.
Trust me.
You're talking about the airline?
I am so sorry.
The flight credits, he was just speaking.
I prefer Southwest.
Sure. Anyone else, wanna speak about this?
I'm jealous.
Counselor Hall Harper, do you wanna speak about the conference at all, or?
I'll go every year.
Very good.
I
Well,
highly recommend. I went one year. It's very dynamic and inspiring, and I think that organization's putting like an outpost in Tulsa. We're trying to
They're trying to.
doing some work here.
We're duplicating, we're working
Well,
on some.
Rep here.
No, I'm
Force up to the.
like bring their maybe I'm misspeaking about it, but
Yeah, the Empowerment Network, we're duplicating that model here.
oh.
And so that's a model that
But
got national attention.
if you've never gone to that conference, it's pretty amazing. So
definitely interested, for
Yeah.
sure. Well, thank you all, for coming today and joining us online. Last order of business, we are adjourned.
And that's because anytime water is turned off, there is a chance your system will lose some pressure and you could see cloudy water until it's restored. Lastly, while contractors work to swap your meter out, they'll also perform what's known as a lead service line inspection.
Lead, which is a toxic metal that was used in plumbing materials in the past,